Okay, welcome everybody to Wall Street Reporter's next Super Stock live stream for September 9th, 2021. We are back with Reliq Health Tech, RHT and TSX.V, and RQHTF. And again, for anybody that's new, our goal is to bring you those stocks which have that 10x to 100x upside. We've already had 8 of them. Stocks are between 13x and 5,000x. We just had the latest one that became a 20 bagger is Peak Fintech. Recently became our second 20 bagger. And now it is time to find out if Reliq is going to be that first potentially 100 bagger. We haven't had that yet. So again, all these companies, they have 3 things in common. One, they're going after massive multi-billion-dollar market opportunities. They're at a key inflection point right now, and there is multiple catalysts in place which can ignite that massive increase in valuation. And again, we're starting to see that Reliq has hit all 3 categories. They've already passed the inflection point. They're moving forward, and we're going to get today actually we're going to do the slideshow today. We're going to get the story in writing on the screen. We get a lot of audience questions. So again, watch the presentation and decide for yourself if Reliq is going to be that 10 bagger stock. So with that said, Lisa, I'm going to disappear.
Okay. All right. Thank you, Jack. As Jack said, my name's Lisa Crossley, and I'm the CEO at Reliq Health Technologies. Quick overview of the forward-looking statements disclaimer. It's in writing here. You can review that at your leisure. So Reliq Health Technologies, who are we? What are we doing? We're a rapidly growing, profitable global telemedicine company. We develop innovative virtual care SaaS solutions for the multi-billion-dollar healthcare market, and we're primarily focused on the US healthcare market, which is the largest single market in healthcare in the world. Our YouGo platform benefits everyone in the system, patients, clinicians, payers. So it's a win-win-win for all of those constituents, as well as obviously for us as a company. We provide comprehensive turnkey solutions to clinicians that allow them to rapidly and easily deploy new virtual care programs that generate high profit, new revenue streams for them. We receive recurring revenue from subscriptions. We are growing very rapidly and organically. So we grow not by acquisition, but through pure organic growth. We have strong margins. By the end of this year, we'll be over 75% gross margins and over 45% EBITDA margins, which is very unusual in healthcare. And we expect to at least double revenues year over year for the next 3 years and beyond. Recent milestones that we've achieved as a company, at the end of June, we hit our revenue run rate that equates to profitability, so $1.5 million a quarter in revenue. That was our run rate at the end of June. The current quarter will be our first full profitable quarter. We've expanded this year across the continental United States as the US has kind of come out from under the pandemic, and moved into Puerto Rico and the US Virgin Islands, which we're very excited about hopefully visiting at some point. We've signed contracts with over 50 US clients. We have over 200,000 patients in what we call our pipeline or our backlog, and that we've got agreed upon implementation plans with the clients. So we'll have that 200,000 patients onboarded by mid-2023. Our average revenue per patient is $40 US per patient per month, so about $600 Canadian per year. So by mid-2023 at full deployment, we should be doing at least 120 million annually in revenues at those high profit margins. And the company does not need to raise capital to fund operations, even with the aggressive milestones we've set for ourselves going forward, those being hitting a revenue run rate of $2 million a month by the end of this year, so by the end of December 2021, and uplisting to the NASDAQ in 2022. I think we're well on track for both of those milestones. I won't read every line of this otherwise somewhat boring chart to you, but one thing I do want to focus on in this is the multiples. So we're currently valued at about an 8x revenues, looking at forecasted revenue run rate for the end of this year. And you can see at the bottom the little notes that typical multiples in this space are anywhere from 5 to 30 times forecasted revenues. But the high growth, profitable companies, particularly those with high EBITDA margins, tend to fetch much higher multiples that are well over 25x. And an interesting example of multiples in this space, if you look at the Livongo acquisition by Teladoc, they were acquired for over 40 times revenues at a point when Livongo was operating at a loss, so negative EBITDA. And so there's certainly, if you have the right company with the right profile in terms of growth, profitability, and margins, and multiples in this space are really very compelling. And I think we, as a company, will certainly fit that target, those target metrics of high growth, high profitability, and great margins. I won't dwell on this slide either. I think most of you know me at this point, and this is the fourth company that I've run as CEO, and I've been CEO of Reliq since 2016. And we have a very strong, very experienced team with not only a lot of depth in healthcare and technology, but also really experienced in bringing new technologies and new ventures to market. And so who are we and why do we do what we do? Well, the problem that we're addressing is the fact that, in the developed nations, roughly 80% of all healthcare spending is down to the 20% of the population who have chronic diseases like chronic obstructive pulmonary disease, congestive heart failure, high blood pressure, kidney disease, diabetes. And in the US alone last year, they spent 18% of their GDP on the chronic disease patient population. So really the only way to reduce healthcare spending is to focus on those patients who have chronic diseases. And the reason they're so expensive to the healthcare system is that these are typically elderly patients who have anywhere from 2 to 8 different chronic diseases. They're responsible for managing these complex clinical conditions in their own homes on their own, and they don't typically do a terribly good job. Less than 50% of them take their medications as prescribed, and that alone accounts for a significant percentage of hospitalizations. And hospitalizations are very expensive. These patients are typically admitted to the ICU when they go in, and you're looking at hundreds of thousands of dollars for that one admission. And the Centers for Medicare and Medicaid Services, who are the largest single payer in healthcare in the world, recently over the last few years have moved away from the typical fee-for-service model. So the more often a doctor sees a patient, the more money they make, to more of an outcomes-based compensation model. So, it's really changed the way that healthcare is provided. And that's created some very strong tailwinds for our company, where physicians not only can make more money by using our software and providing proactive care, but they can avoid significant financial penalties from Medicare and Medicaid. So our software, we're a cloud-based software as a service provider, and we have a modular software platform. We also offer care management services. Basically allows us to function as an extension of the physician's office on kind of an administrative basis, which helps physicians onboard more patients faster and generate revenues for themselves faster. And with our platform, clinicians can easily, seamlessly begin to offer a very broad range of new virtual care services, including remote patient monitoring, behavioral health integration for mental health care, and addiction care coordination, basic telemedicine, transitional care management for post-discharge from skilled nursing. So it's a very, very flexible, powerful, comprehensive platform. And with our care management services, we're really offering kind of a cradle to grave solution for physicians. We do everything from pre-authorizations, electronic pre-authorizations, to Medicare and Medicaid when we get the patient lists from physicians, and through the delivery of care, and then all the way up to electronic claim submissions to Medicare and Medicaid on behalf of our clients. A quick use case to kind of give you an example of how our system functions when it's used by patients out in the community. So if you have a patient who's at home, living on their own, they have chronic obstructive pulmonary disease, and they start to have decreasing lung function. So with typically any chronic condition, and you'll see that patients' health will start out at a certain level, let's say we'll call that a 10, and it'll gradually decline to sort of a 4 or 5, at which point they need to be hospitalized with one complication or another. And they rarely ever get back up to that 10. So you have this patient, they're at home, their lung function's starting to degrade. They either don't remember to check their lung function with the spirometer they're supposed to blow into every day, or they don't remember to write down what it was yesterday so they don't notice that it's declining, or they don't remember what they're supposed to do when they start to see that decline. And so essentially the patient allows the condition to deteriorate for a period of days, finally notices that their lips are turning blue, they're having trouble breathing, they can't do normal activities, and they go to the hospital, where they're admitted to the ICU with pneumonia, often caused by that shallow breathing that COPD patients get as their lungs become more inflamed. And they're often experiencing hypoxia as a result of that, so low oxygen levels through the body, and can end up in multiple organ failure. And a lot of that hypoxic damage is permanent. So leaving these patients on their own in the home tends to not only result in these frequent hospitalizations, but also in long-term poor health outcomes and poor quality of life. If that same patient is using iUGO Care, after a few days of the spirometer readings showing a trend towards lower lung function, the care team will receive an automated alert saying this patient needs some attention. The physician can call in a new prescription, maybe an oral steroid or a change in their inhalers, either the bronchodilators or the inhaled steroids, or they can send over a respiratory therapist, but they can keep that patient healthy and at home. They can avoid any further inflammation, avoid the development of pneumonia. They can even proactively prescribe antibiotics, and they can prevent any organ damage from hypoxia. So these small interventions in the home have a dramatic impact on not just health outcomes, but ultimately on healthcare spending by avoiding those multi-hundreds of thousands of dollars admissions to the intensive care unit. So the benefits of iUGO Care for patients, it's obvious, better health outcomes means better quality of life, better patient satisfaction, and it reduces hospitalizations, which are not just costly for both the patient and the healthcare system, depending on their insurance, but are also really disruptive to not only the patient, but their entire family. For providers, doctors, home health agencies, other clinicians, we're creating new revenue streams. And so there's compelling reimbursements from Medicare and Medicaid for deploying proactive, preventative virtual care programs. And they avoid financial penalties. So Medicare and Medicaid can claw back several percent of the reimbursements you've received in a given year if your patients are hospitalized more often than the average Medicare or Medicaid chronic disease patient. And so driving those better health outcomes not only creates new revenues, it avoids the loss of some of those revenues to penalties. And when we started in 2018, there was one billing code for remote patient monitoring, and clinicians could make $59 per patient per month. And they can now make $372 or more per patient per month, US dollars, by deploying iUGO Care. And they're only paying $40 to $100 per patient per month for the subscription to iUGO Care, depending on whether they're using just the software or also the care management services. So these are very profitable and new revenue streams. And the average practice can generate over $1 million in new high profit margin revenue by deploying our platform. So that's created tremendous market pull. Our revenue model and opportunity, we're targeting the $100 billion US virtual care market. We also do have some opportunities in Australia and Canada, and we'll be looking globally as the company grows, but primarily in the US, we're focused on the 37 million Medicare and Medicaid patients who have 2 or more chronic diseases and therefore qualify for a broad range of virtual care services. As Medicare and Medicaid has continued to expand on the program, there are even more patients who are eligible for our services. And we charge subscription fees, which are paid by the clinicians. And so our clients are the clinical care providers, whether they're doctors or home health agencies or skilled nursing facilities. And we charge an average revenue per patient of $40 per patient per month. And on the very low end, we might have some deployments where patients are assessed subscription fees of $25 per patient per month, but more and more we're seeing the subscription fees at the $100 per patient per month level as clinicians begin to adopt and demand more of our care management services. Excuse me. So our growth forecast, by the end of this year, we expect that we'll have done about 11 million in revenue. But more importantly, in terms of what the institutions, the analysts look at when valuing companies, by the end of this year, we'll have hit a revenue run rate of 2 million a month or 24 million annually. We expect that next year we'll do a minimum of 32 million in revenue and at least double revenues every year going forward for the foreseeable future. So I think, we're looking at least $1 billion valuation by 2024, if not sooner. And one of the big drivers for valuation for us is those compelling gross margins of over 75% and EBITDA margins of over 45%, which we'll achieve by the end of this year. Trends and tailwinds. So there's a lot of factors right now that make this kind of the perfect storm for Reliq in terms of market conditions. The population is aging and growing, and because of lifestyle choices, and the percentage of the population that has chronic diseases is steadily increasing. So there's going to be increasing demand for our platform for decades to come, frankly. As I mentioned earlier, CMS has introduced financial penalties for clinicians whose patients are hospitalized with preventable complications, which is really what we address and prevent. And since we started in 2018, when there was one billing code and that CMS had just introduced for remote patient monitoring, to now, there's now over 18 billing codes, and next year Medicare and Medicaid are introducing an additional 5. So there's clearly a commitment on the part of Medicare and Medicaid to continue to fund these programs and to expand them both in terms of scope and in terms of the value of reimbursements, which have gone up by over 500% in the last 3 years. And the implementation of virtual care programs, the reason that Medicare and Medicaid are willing to financially incent clinicians is because of the savings that they translate to. So if you can bring the cost of care for a patient down from several hundred thousands a year to under 4,000 a year with our platform, that makes very good financial sense for Medicare and Medicaid and makes their health insurance system sustainable going forward as the population ages and grows and there's more demand for services from the payers. So over the course of a year, CMS can save tens of billions of dollars by having these super users of the system, the chronic disease patients, receiving more proactive preventative care using virtual care platforms like Reliq. And that's just a brief overview of our company. I will stop sharing now and let Jack ask any questions that he may have.
Okay, we got a bunch of audience questions I want to get into in just a second. But first, I just want to kind of recap a couple of important things. So one is, so you're on track right now to hit $2 million per month of December.
Yep.
So 24 million run rate.
Mm-hmm.
And I think, look, I think with that, if you can get to that number, you can, that could get the company to $1 billion valuation, because the market is, in the health tech space, with Livongo, et cetera, it's again, it's forward looking. It's looking at 30 million. So things get, people start extrapolating out.
Yeah.
So that would be $5 plus. Very important is and again, that's just and you're still adding new contracts. Today you announced another new contract. And we're going to talk about the onboarding. Again, one of the big questions people ask is, okay, what about the onboarding? What about the onboarding? The contracts, okay. So you got that's in. So you got this new contract. This is in Puerto Rico, so it's a new market. And let's see. Okay, and the other, I think one of the big takeaways is essentially you're at you don't need to raise capital, really. In other words, you can maintain this level of growth. Essentially, it will be self-funded. It will be funded from just internal cash flow coming in through monthly revenues.
That's exactly right. We're not going to need to raise capital beginning, Q1 of next year. We'll be throwing off pretty significant amounts of free cash. I saw a question that's relevant flash across the screen asking how our EBITDA margins will grow. So, essentially the EBITDA margins will hit 45% by the end of this year and basically stabilize there. So, they're lower. They've been lower this year because there are certain fixed costs with the business, around our entire team. But as we grow, where you'll see a scale in staff is really around the care management center. So those are are relatively low cost resources, which will allow us to maintain those margins. But, we basically, 45% is kind of our target. You may see some improvements with economies of scale as we move forward, but that's about where we'll be. But with those kinds of margins, you are taking home a significant amount of cash with the amount of revenue that we're projecting that we'll be generating. So, we don't expect that we'll need a raise.
Okay, interesting question. So Jeremy's asking, can you talk about the organic growth as in upgrading patients to more premium service packages and clinics onboarding additional patients as the billing codes change? So one of the big drivers is this, maybe, and you can maybe address this, the changes in Medicaid, Medicare, the billing codes, and what that really means.
Yeah, I mean, when we started, there was one billing code for remote patient monitoring. Now there's multiple billing codes for remote monitoring, including some new billing codes that they call remote therapeutic monitoring that'll be introduced next year. But we basically are able to offer a whole new suite of services, including behavioral health integration, chronic care management, transitional care management, principal care management. So when we started, you couldn't deploy any kind of remote patient monitoring if you were a specialist, and now you can. So we definitely do see an increase in the number of services, the number of modules of our platform that existing customers are using. And we also see a lot more demand for our care management center. We didn't have that when we launched in 2018. And we started it to try to support physicians who were wanted to deploy our system. It lets them onboard patients much faster and start generating revenue and driving those better health outcomes much more quickly. But we didn't actually expect quite the demand that we've had. So that's a very positive thing for us. It will help increase our average revenue per patient. But it's a very positive thing for physicians too, because it really is, it takes a lot of the burden off of them and allows them to deploy very quickly. And I think the increasing reimbursement levels have really made them feel comfortable with, sort of subcontracting that piece out to us, the care management piece, because there's still so much money to be made for the clinician, even if you are paying, the premium fee to have us do the care management.
Great question. What can go wrong, basically? Do you see any obstacles to reaching your run rate target by December?
I think I've said this before, this company has really been battle tested. We've faced a lot of unforeseen obstacles over the year, from wildfires in Australia to, a global pandemic. We did really kind of closely watch the Delta variant as it started to become a really significant issue globally. But what we found is that, in fact, the clinicians who basically shut down their practices to anyone other than COVID patients for the first year and a half of the pandemic are now recognizing that they can't keep their chronic disease patients on hold indefinitely, and we're going to be living with the pandemic, with this virus, for a while. So they've really come around to wanting to be able to offer something virtual to those at-risk patients, and that's definitely driving growth. So for us, I think the big risks would always be if we were hiring human resources that were really rare or difficult to source. But where we are hiring on the care management side, we can hire medical assistants who can work from home anywhere in the US. And there are a lot of medical assistants and nurses and LVNs, so, kind of nurses, aides, that are available. So, we don't have any shortage of potential staff to add. And I think with the Delta variant, one of the things that we found is those clinical resources are really desperate to be able to work from home and not have to work in an acute care setting. So that's, really created a lot of demand for the positions that we're hiring into. So I think we're very much on track for hitting our revenue milestones. And I think next year for vastly exceeding them.
Okay, we got a bunch of good questions that came in. So Lisa, I hope you have like a little time.
Yep.
Okay. So so
good question.
To seeing the cash coming into the account.
Yeah, so basically a patient has to be on the platform for at least 2 weeks before the clinician can bill for services rendered to that patient. In some cases it's a month, but so let's say worst case it's a month. And then our terms with the clinicians are net 60. So we usually get paid at the outside within 90 days of a patient first being onboarded onto the system.
Okay, so 90 days after somebody actually is onboarded, you have cash in the bank?
Yes.
Okay. Josh is asking, didn't Livongo get bought out, and they only had 2 billing codes.
So Livongo, that's interesting. Livongo actually doesn't leverage any billing codes because their platform is too expensive for Medicare and Medicaid. So Livongo sells to employer self-insured plans where they can charge a higher premium, and they're dealing with younger patients. So these are patients who are working age, and therefore tend not to be as complex as our patients. And they use sort of the more consumer focusing technology like apps that won't work with the elderly patients that we deal with. They also rely on patients having internet access, which is actually fairly rare with our patient population. So that's why we connect to a lot of these cellular monitoring devices. But I think it's a very good point. Livongo got bought, even though they only focus on type 1 diabetes, and that's 10% of the total diabetes market and a fraction of the total chronic disease market. It also doesn't cover all of the other new billing codes or other new initiatives, which include things like behavioral health integration, mental health care coordination, care for opioid addicted patients, and everything else that our platform does. So yeah, a very limited platform with a relatively narrow audience compared to ours.
Okay, so we have Chris. Now, Chris is going to have about 7-8 questions, very detailed questions. So,
yeah, that's okay.
Granular details. Okay. Can you see the question? He's asking, can you expand on your care manager? Did these include clinical call centers to follow up with patients?
Yeah. So our call centers, they're acting as an extension of the physician's office. So the patient will never get a call from Reliq Health. They'll get a call from their physician's office, and that may be our staff if that physician is using our care management services. And our typical staff are medical assistants. So in terms of clinical qualifications, there's sort of doctors, nurses aides, medical assistants. So they're very inexpensive resources. They're not prescribing medications to patients or making treatment decisions, but what they do is, they spend time reviewing the patient's chart, making sure care plans are up to date. The patient doesn't have a 2-year-old care plan in there, and those are billable services. And then they'll when a patient receives the devices for the first time, they'll give them a call and make sure they know how to use it, plug it into the wall, do what it says. When it says prick your finger. And they'll also call patients who maybe have forgotten to take a reading for a day or two. So they're doing kind of more sort of medical administration services on behalf of the physician's office, and it alleviates a lot of the burden on the physician's office, but we're not responsible for any kind of diagnosis or treatment. It's not like the patients can't call our call center, we call them, but the care management center is entirely staffed with clinical personnel.
Okay. Okay, he's asking, in terms of hardware, how are you able to be hardware agnostic? In other words, how is your platform able to collect data from many different producers of hardware?
Yeah, so we built the platform so that we'd be able to connect easily to multiple different, not just hardware platforms, but also software, so that we can integrate with various EMRs. And there's a lot of different ways that we connect to different pieces of hardware, depending on whether they have SDKs or APIs or what's available. But it was really important to us to be hardware agnostic. We want to be able to support clinicians who have patients who are at home on kidney dialysis machines, and they can collect the data directly from that machine, or they're using CPAP because the masks that help you breathe continuous positive airway pressure for sleep apnea patients, as well as tracking for dementia patients if they wander out of the home, or doing falls detection. If you can offer a clinician a one-stop shop where they can monitor all of their patients with a very diverse range of clinical conditions on one platform, that's a huge competitive advantage, and really is a key differentiator for us in this space.
Okay. Next question. He's asking, okay, so doctors often don't want to pay for the equipment out of pocket.
Doctors the doctors don't pay for the equipment, and the patients don't pay for the equipment. It's paid for by Medicare or Medicaid. And so, there's no out-of-pocket expense around that hardware. Certainly, doctors are not keen on capital expenditures. So that's part of why it's really important that we're hardware agnostic, so that we are able to work with whatever device is actually reimbursable by Medicare and Medicaid. Whereas if you are a company, as many device manufacturers are, that has software but only works with your proprietary hardware, your hardware may not be eligible for reimbursement under Medicare and Medicaid. And that's a huge disadvantage if the doctor actually has to pay, or the patient.
Okay. Okay. So next question. How involved are you with onboarding? How are you ensuring that doctors actually onboard all their patients? Do you help with implementation, training, etc.?
Yeah, for the most part, we own the onboarding process. So every once in a while, we'll have, particularly with home health agencies, they have the resources, they want to do the onboarding. There's billing codes for them to actually go out to a patient's house and hand deliver a piece of equipment, show them how to use it so they can generate revenue that way. But for the most part, the physician will download a patient list for us from their EMR or give us, access to the EMR, and we'll download the patient lists ourselves. And then we coordinate everything, including, having devices shipped to the patient and contacting the patient and getting the informed consent from the patient. And we do the pre-authorization. So we actually basically run that patient list through the Medicare, Medicaid databases and obtain pre-authorizations for those patients. So we know that when a patient is added to the platform, they are eligible for our services and the physician will receive revenue. And then we do the electronic claim submission after the physician has delivered the services or after the patient's been on the platform for 2 weeks to a month. So we really kind of manage all of that that piece of the business on behalf of our clients because it just means we can onboard a lot faster.
Okay. So Chris, a follow-up question. Don't you have to wait for the reimbursement after they provide the equipment? So
So typically what will happen is a physician will write a prescription for that particular device. It'll go to what they call a durable medical equipment provider or a DME. And that DME will send the equipment, but they're billing Medicare and Medicaid directly. So there's no capital outlay on anyone's part. In our case, with some of the hardware that we have in inventory, there was a particular hardware shortage back in 2018 around a type of device that's both a glucose meter and a blood pressure cuff in one, and that is cellular enabled. So it was a sort of very unique device that was really needed in some of the remote and rural communities. But there was a hardware shortage, so we end up purchasing a bunch of devices so that the manufacturer would invest in making more of them. And so now when we have a deployment, we will either include if they want those particular devices, we are almost out of inventory, so that's not something we'll be doing long term, but we can either provide those devices up front and help coordinate the Medicare and Medicaid reimbursement. We've already paid for those devices ourselves back in 2018, or we can roll that cost into the monthly fee for the clinician if the clinician wants to actually own those devices and potentially reuse them down the road. But generally going forward, we're not really involved on the hardware side.
Okay. Chris is asking, is the call center outsourced?
Yeah. Sorry for hijacking the Q&A.
Well, he's usually, we haven't seen him in a while. Sometimes he asks like 12, which is good. He asks a very good question, so I don't mind. Of course, you can ask as many questions as you want.
It's not outsourced. We own the care management piece. We have a call center in Florida, but basically as soon as we opened it, the pandemic hit, and you know how well Florida has done through the pandemic. So most of our call center staff work from their own homes, and we now have call center staff members in multiple different states. It doesn't really matter as long as they're somewhere in the U.S. So that they're licensed.
Okay, if there's a brand new device that comes out, how will you be able to connect to that right away?
Yeah, generally device manufacturers make it pretty easy to connect to their devices because that's how they sell more devices. And so we're able to connect quite quickly to new devices. Occasionally there'll be proprietary devices that really don't let anyone connect to them except through their own software, but those usually don't do well in the market because if you can only use their proprietary software, then you're monitoring one condition through this hardware, and that's not practical, and that's not something that physicians will use.
Okay, Josh is asking, do you expect some significant new customers this quarter, new or existing clients that just expanded their users?
Yeah, no, I think definitely we are in a phase where we're acquiring a lot of new clients, and I think where we started out working with kind of individual physician practices and home health agencies, we've scaled that up significantly to working with networks. So, this quarter ends in a few weeks, but certainly by the end of this year, I think we will be able to demonstrate significant traction with larger scale new clients.
Okay, so you cut out at the end. You're saying you were.
I was saying that, by the end of this year, this calendar year, so within the next few months, we will have gained significant traction. We expect to gain significant traction with some new large-scale clients.
Okay. Michael's asking, for some of these contracts where onboarding is expected over 18 to 24 months, are they locked in, or can competitors technically come in and offer a low price or whatever?
I mean,
how secure are these?
Yeah, you have to keep in mind, we don't have head-to-head competition in this space. So we don't go in and bid against other companies because there's no other company that does what we do. Between the care management piece, the fact that we're a multilingual platform, so we can deploy in any language. We have a very unique patient experience. If you look at what's historically been done with remote monitoring and with apps on a tablet, those don't work with the elderly, sick patients. And most companies are not prepared to deal with patients who don't have internet access. Most of the remote monitoring solutions that have ever been developed rely on those apps on tablets where you're pairing a device by Bluetooth. The elderly and Bluetooth do not mix well. So, Bluetooth is inherently unstable, and you're constantly having to repair those devices. That's not possible for these patients. A lot of them are, quite sick. They have visual acuity, memory issues. So we have a very unique patient experience. Looking at our deployments in the U.S. Virgin Islands, in rural Texas, in excuse me, Puerto Rico, we can't rely on neighborhood internet access. We're definitely using, cellular, and we're one of the few companies that can do that. And we have a very comprehensive platform that leverages all of these new billing codes, which nobody else has. So, we've also got the advantage of, we've established ourselves as the standard of care in this space, the community care space. So if a new competitor comes along, they don't have 3 years of data showing that they actually do prevent hospitalizations and ER visits. They don't have 3 years of data showing that their clinician clients are receiving Medicare reimbursement. This is a very conservative market. If you look at, as an example, the hospital EMR space, electronic medical record space, there's 2 companies that are massively the 2 major market shareholders, even though their software is complained about by everyone who uses them. So getting that sort of first to market advantage and establishing yourself as a standard of care is a very long-term sustainable advantage in healthcare, and that's an advantage we have.
Okay, so I think it's a very important point that you mentioned, is that you actually have, empirical data. You have 3 years, which you can, and again, doctors, the healthcare system, it's very, very conservative.
Yeah.
So if you can show, insurance companies, et cetera, that, hey, you spend X and here is the payoff.
Yeah.
This is, this is what they need.
Yeah.
And again, that's a massive competitive advantage. That gives you a massive head start.
Right. We have, established ROI models based on data, and that's a huge competitive advantage. And in this market, more customers buy by reference than any other method. So, advertising isn't typically very effective. It's really just, you have to, get out there, establish yourself as the standard of care. And in our case, we have incredibly user-friendly software. We see, 99% adherence rates in our patients, where, other companies, they get 0% adherence after the first week or 2. And so we really have a very solid product, and we are seeing that buying by reference now. We get more calls inbound than we could possibly ever go after, new clients on our own. And that's really how you've got the right product for the healthcare market is, one clinician is using it, they're making money, their patients are doing well, they tell 6 of their friends, they tell 6 of their friends. It's that old shampoo commercial from the 70s. And, they tell 2 friends. And that's really what you need to model your business on in terms of being in healthcare. You want to make sure that you get out there, that you capitalize on your first to market advantage, and that you do a good job so that you do get those reference customers and get those referrals. Those will really be what drives your business. And there's no new entrant to the market who could come along now and get to the point we are with that, the solid references, the credibility, the referrals. It would take years.
No, it's interesting. Okay, so Chris is back. He's got more questions. I knew he wasn't done. Okay, so it says you have smaller companies like Care24, Dario, who are cheaper than RHT. Do you not see it as competitors because of what's your take?
Yeah. So, for example, Dario, we've run into them in the market before. We very quickly and easily displaced them because they have proprietary hardware. Their software only works with their hardware. So you can only monitor patients who have the clinical conditions for which Dario has hardware, which is by no means everything. And they also don't do behavioral health integration. The reason that those platforms are cheaper is because they are much narrower, so they don't allow the clinicians to provide the same kind of care. And for the most part, most of those platforms are actually patient facing. So, there's an app, there's software that goes with that hardware, but it's not aimed at clinicians. It's aimed at patients. So you can share that data with your clinician, but they can't bill for it. So there's no revenue for the physician associated with a lot of those hardware specific software platforms. And even for the ones that, do have a physician facing component, because you're monitoring a narrow range of conditions and you're not doing everything else, the chronic care management, the care management services, the physician's going to get a really low level of reimbursement for that. So when clinicians are using software like that, there are hardware manufacturers that have physician-facing software that they're paying $5 a month for, and they quickly switch to us at $40 to $100 per patient per month because it makes a huge difference in how much revenue they're going to generate. And it also has a huge impact on the quality metrics for the physician. So those narrowly focused hardware-specific software platforms don't typically drive significant improvements in health outcomes, whereas we do. So we help the physicians avoid those penalties.
Okay. One more question from Chris, and then we'll. Okay. So, Chris, you need to number the questions. I think last time we had Chris with Cloud MD, if I remember, he had like question number 1, 2, and he had like I think 8. We have a record here, so which is a good omen for Reliq. So so he's asking, why do you think there hasn't been one main player who has been able to establish themselves in the space? Is it only because of the billing codes?
No, I mean, that's part of it. Certainly, up until the last year or two, this wasn't a particularly compelling space for most companies. There weren't very many billing codes. When we started in the market in 2018, we were very much missionaries. Physicians hadn't heard of these new billing codes, didn't know what to make of them, didn't consider the level of reimbursement really worth their while. And then there were a lot of hiccups with Medicare and Medicaid, as there often are when they first roll out a program, where they were, denying eligibility on patients who, in theory, were eligible. So, there was some hair on the market, let's say, back 3 years ago. So it's a relatively new market. But more importantly, I think overall in healthcare, the budget has traditionally always been aimed at the acute care space. So that's where all the money went, was into hospitals and anything related to hospitals, including post-discharge care. And so there were companies, Vivify and others, who really focused on remote monitoring for the post-discharge period. But that's a 30-day period, so you have a lot of churn of patients. And it's really tough to make money in that space. Hospitals are very needy clients, and those are very expensive solutions. And no one really could figure out how to translate those existing platforms that were aimed at hospitals that cost millions of dollars to install and millions of dollars to support and require a hospital IT team that's dozens of developers to support it. How do you translate that into the community market where there's no IT support? Doctors don't have a capital budget, so they're not going to be able to spend a huge amount of money upfront to deploy your solution, and they're not going to want to use something that requires a lot of support. And so we built a platform specifically for the community care market based on our very deep understanding of that space. I grew up in a hospital with chronic disease patients. Literally from 3 weeks old, I was in that hospital with my mother, who ran the stroke unit. And so we understand the patient population and have a very good patient experience. And I think a lot of tech companies really struggle with the concept of providing that very low tech experience to patients, but that's what you have to do to succeed with these particular patient population, the older sick patients. And most of the companies in the space were so focused on hospitals and these very complex systems that they just couldn't pivot to the community care space. And with the billing codes being so low, there really wasn't a particularly strong business case there. So we were able to kind of sneak in there and, being fairly forward-looking ourselves. And, I've wanted my whole career, my whole life, to improve care for chronic disease patients in the home. So we had a head start, and now that we've built that credibility, we have a sustainable competitive advantage as the first to market in that space, where we can can really be all things to all people in the community, because we offer such a broad range of services that are supported by our platform, along with our care management services.
Yeah, I mean that's really like part of the whole of Reliq is this, you occupy this, really unique space. It would be very hard to displace, Reliq. So you have this very strong competitive moat, which is why you can get this massive valuation at once you hit that. Because when I talk about, billion, it's not a crazy number, because we've seen those types of numbers paid for those unique situations. It's not, and a couple $1 billion is not a big deal for a company like a Teladoc or whoever. I mean, even $2 billion is nothing these days for these guys. Amazon, let's say Amazon. I mean, I'm not saying Amazon, but let's say they want to get at that space.
Teladoc paid $18.5 million. Okay, let me start that again. Paid $18.5 billion for Livongo at a time when Livongo's revenues were around $400 million a year. So, an over 40 times multiple. And Livongo is operating at a loss. They have an adjusted EBITDA metric that they like to trot out that's positive, but operating at a loss. And going forward, both of those companies are looking at single-digit EBITDA margins, best case scenario at scale, because their platforms, their solutions rely very heavily on human resources and a lot of not just monitoring, but coaching and things. Whereas we've defined a patient experience that really works for the elderly patient, lets them feel very autonomous and independent, but gives them a safety net, and really does clinically, we've proven, reduce complications and therefore hospitalizations and the associated healthcare spending. So, I think there are very compelling multiples being paid out there for companies that have far a much smaller potential addressable market than we have. Just we have legs in a way that most companies don't.
Okay.
Yeah,
the new contracts that RHT is announcing, are those in addition to the backlog or included? Where do they fit in?
Yeah, for the most part, they are not part of that backlog. They're new. In some cases, particularly with some of the challenges around the pandemic, we've had some clients shift their onboarding to early next year from this quarter. So, it's still going to come out to the same basic revenue run rate at the end of this quarter. But in terms of the overall backlog that we expect to have onboarded by the middle of 2023, that's growing every day.
Okay, I think this is going to be the last question. Okay, Chris, yes, okay, can you touch on the physician's job? Basically, doctors don't like to do, how were they involved?
Yeah, so it's interesting. We were just talking about that on a staff meeting. Basically, the physicians do almost nothing to do with deploying our platform. Everything that's done is done by their office administrator or director of nursing, and the physicians really don't have to do much. Even the alerts often are funneled at the physician's request to the director of nursing or to another staff member, and then the physician will be called in if the prescription change is warranted or something that requires a physician. But the doctors are not required to be involved in any way in order to get us set up. We can work with your office manager to download that patient list. The EMRs allow the physician to quickly and easily sort based on, or the office manager to sort based on the clinical conditions. And so there's very, very little involvement from the physicians themselves, except upfront when they're, looking at the platform and deciding whether or not they want to buy it. They are certainly the ones who make the decision on purchasing, but from there on, everything is delegated to somebody else in their office.
Oh. Lisa, thank you again. Thank you, everybody, for joining our live stream today. Thank you, Chris, for all the questions, and we'll see you all in the next live stream.
Yes, and the slide deck I presented today, which is new, will be up on our website by tomorrow.
Fantastic. Thank you again.
Thanks very much.